which is the last seminar on CNS tumors. Next slide, Dr. Pooja. The chairperson for today's seminar is Dr. Tejpal Gupta, sir, who is a professor, Department of Radiation Oncology, Khalgar, Navi Mumbai. The presenter of today's seminar is Dr. Sridhar Ipari, sir, who is a professor, Department of Pathology, Khalgar, Navi Mumbai. And this is the list of today's participants. I have divided them into 5 groups for their convenience. I request them to introduce themselves one by one.
Maybe Neha, maybe can they introduce themselves when they're presenting the case?
Okay.
Is that okay?
Oh.
Yeah.
Yes,
fine.
sir.
Yeah.
Now, the host of today's webinar are Dr. Anita Borges ma'am, Dr. Sunil Gujral sir, and these are the moderators, me, Dr. Pooja Gajaria, and Dr. Chandra ma'am. These are the few reminders, disclaimers. And these are the upcoming talks. Our next talk is on 3rd April on how a pathologist can suspect immunodeficiency by Dr. B. Saiker sir.
Neha, I just
Yes,
corrected that we have teacher is Dr. Amit Rawal, who is professor at PGI Chandigarh of Pediatric Immunology. Biman Sekar is not teaching. Dr. Amit Rawal. Yeah.
Okay, sir. Okay. On 8th April, we have next slide seminar on immunotherapy, principles and case-based applications, including CAR cell by Dr. Jyoti Prashant sir and Dr. Albina Nisar. So let's start the seminar. Now over to you, sir. Sridhar sir.
Yeah. Thank you.
You're
Thank you,
sharing the screen. Yeah.
let me share my screen. Able to see my screen?
Yes, sir.
Yeah. So good evening, all of you. At the outset, I really thank Dr. Anita Borges and Dr. Sumit Gujral for giving this opportunity to interact with the students on this online platform and to discuss about cases of brain tumors. Okay. For all the postgraduates who are there here, I just wanted to say that brain tumors are not a common malignant. It's a very uncommon malignancy. Probably it will not come as a first order learning exercise, but to complete your post-graduation and to complete the knowledge spectrum, this is important because the dynamics and approach to the new CNS tumors are certainly different from the rest of the solid tumors. Okay. So in this session, we will be talking based on the current WHO classification, which is that CNS5 WHO classification. It classifies the brain tumors into broad disease family groups, as it listed here. The most common, the biggest group of tumors are glioma, glynurinal tumors, and urinary tumors. We will touch few cases on that. And the second most common tumors are embryonal tumors and the mimics, especially our histological mimics. We'll touch the cases upon that. For the ease of discussion, I divided the cases into certain groups, which can be clubbed together in a group of tumors. So let's start with the first one, group like case group A, which is essentially deals with the adult diffuse gliomas, which are the commonest brain tumors, which everybody will come across with these tumors in their practice. So the person whoever can introduce himself and take this case.
I request Dr. Aviral and Dr. Vivek to introduce themselves.
Good evening, sir. I'm Dr. Vivek from Darbhanga Medical College, Bihar, PG senior.
Okay, Vivek, you're into the second year. You have any exposure to the brain tumors?
Yes, sir.
No problem. You just go through the slides. You try to describe the way what it is. We will see how we can reach up to. You're taking the first case?
Yes, sir.
Okay, can you read out the history?
A male age 35 years is complaining of seizures, which is GTCS, since 1 year. There was history of fall from wheelchair 10 days back.
That was a brief history. What is the history here shows that young male, GTCS is generalized tonic-clonic seizures since 1 year. So it's relatively a longer history. And when the generalized tonic-clonic seizures are there, it indicates that something is affecting the cerebral hemisphere. Okay. Whenever any patient comes with the generalized seizures or any form of the seizures, the first investigation is imaging. So this is the MRI. So MRI imaging showed a lesion involving bilateral thalami, hypothalamus, left ganglioscapular region, and also the temporal lobes. So when T2 hyperintense mean, there is saying that more fluid or cystic spaces is there, lesser. And there is no diffusion restriction, suggesting that the cellularity is not too much. There are lesser degree of cellularity. Raised colony creatine peak is suggesting that probably it is reaching into the higher grade. So MRI findings, what you can see, a lesion which is diffusely infiltrating extensively into the cerebral hemisphere. Is that clear?
Yes, sir.
So the biopsy, a sort of biopsy to be done because we cannot debulk the tumor. So this is the picture. Can you describe this? Vivek, can you describe?
Yes, sir. There are two types of cells in.
So whenever you start seeing the first thing when you see a brain lesion or a brain biopsy, first thing what you have to see is you need to comment the cellularity. Cellularity in respect to the normal parenchyma. So what are you seeing?
So there is oval. There are some oval nuclei.
So the cellularity is certainly more than what you expect in the normal cellularity. Okay. Then are you seeing any ordered architecture? You are not seeing any ordered architecture. You are not seeing any native ganglion cells. It is showing a moderately cellular tissue. Now you tell what are the types of cells.
There are two types. Like one is of the oval or round type, and another is flat or hyperchromatic type.
So what Vivek told is probably descriptive appropriate, but what is interesting, you need to say that you're seeing a tissue which is moderately cellular, little bit more than the native cellularity, and composed of cells of varied morphology. You can't pick any two cells which are similar. Like each one, the cells are different to each other. Some are oval like this, some are indented, some are hyperchromatic, some are irregular. So what is it like? You want to make any opinion on this, or you want to see any further?
So you can see further, sir.
Yeah, this is a little bit higher magnification.
Yes, sir.
So what are these cells? These are native oligodendrocytes. Okay.
Yes, sir.
And what is this one? You're able to see my arrow?
No, sir.
No. Okay. Describe anything further on this? Any further information?
So there is some that round nucleus. There is the clear cytoplasm that is oligodendro.
Site-like morphology. So when you are seeing a moderately cellular lesion, which is more than the expected normal cellularity, at least tells you that this is a lesional tissue. Yes?
Yes, sir.
Now, lesional tissue, when you come across, what is the evaluation? Whether it's an inflammatory, whether it's a tumorous, or anything else. Did you see any inflammatory cells here?
No, sir.
There are no inflammatory cells. And also, you can see a varied morphology here, cells. So, likely to be a
Rigid
tumor.
endogram.
Likely to be a, what do you feel? Likely to be tumor or non-tumor?
Tumor.
Tumor. Yeah. So what is? So now you keep your radiological findings in your mind. It's a diffusely infiltrating lesion. You saw some moderately cellular lesion. Cells of varied morphology. So an infiltrative lesion, tumor-like. What are the diffuse infiltrating tumors in an adult? 35. Anybody, Vivek or?
Sir, grade 2 in astrocytoma, sir. Anaplastic and glioblastoma, sir. Infiltrating.
So adult diffuse gliomas are 3 subtypes in the current classification. Diffuse astrocytoma, IDH mutant, oligodendroglioma, IDH mutant and 1p19q co-deleted, and glioblastoma. So anything which is IDH wild type is glioblastoma. IDH mutant can be 2 types. Astrocytoma alone. Now what is your histological impression? Impression was a tumor of which cells, probably you want to call ambiguous morphology. You have to describe like oligo-like morphology as well as astrocytic cells, right? Diffuse glioma did not see any high-grade features. So what do you want to do? Anything further you want to do, or you want to give the impression?
So I see for that.
You want, what is the IHC panel you like to do?
Go for IDH only.
Very good. First, as you see the adult infiltrating tumor, you need to go for IDH mutant. So how do you test for IDH mutation?
We'll check for 134 on that one. Type.
No problem. So this is the commonest mutation of IDH is IDH1 R132H, which can be detected by immunohistochemistry. It's a cytoplasmic marker because IDH is a mitochondrial enzyme. You can see that. So what do you see here in IHC? How do you interpret IHC for IDH? Have you seen any IHC slides, Vivek?
Yes, sir.
So anybody, how do you interpret this?
So this is moderately positive.
So what is 132H mean? R132H mean? So IDH R132H is mutant specific antibody. So it only detects the mutant protein. So here you are supposed to say either positive, that means mutant, or negative. There is no role for intensity or focal positivity or negative one. You can see here there is a mixture of cells. There are some cells which are negative and some cells which are positive. All the positive cells are the tumor cells, which are admit to the native parenchymal cell which are negative. So IDH1 R132H is positive. Means what? Yes, means it is IDH mutant for R132H. IDH1 mutant. Next, what you want to do, Vivek?
So that the code 1p19q correlation test, sir.
So directly you want to do one. Is there any immunohistochemistry which you want to do it further? Before you want to do one? Yeah. Why ATRX? Why ATRX?
Because it is like if it is present, then it's present in tumor cell, absent in tumor cells, sir. And
So if it is absent in tumor cell, what does it convey? Okay, let's see. What is this one? This is ATRX. How do you interpret this?
it's present to a lesser extent, sir.
Now lesser extent mean? So when you go back to the previous picture, you can see that there are some IDH negative cells. These are normal cells. Okay, ATRX protein, unlike the IDH, is normal protein. When all the normal cells are positive here and the negative cells are the tumor cells, the predominant cells are negative. That means the tumor is showing ATRX loss of expression. You can see here endothelial cells is retained. So ATRX is lost. ATRX is lost means what? The protein is not translated. So there are mutations which is causing silencing of the gene ATRX loss. What does it loss? What does it imply?
Astrocytoma.
Yes, astrocytoma. So now that what is so next is for an ATRX. So normally when it is retained, you can see the picture. You can see all cells are positive. You can see this protein here. This is a picture of protein retained expression. When this kind of picture you see this figure coming out is a loss of expression. Few points to remember: ATRX is a nuclear strain, whereas IDH is cytoplasmic strain. The ATRX labels the normal protein which is present in all cells. So lack of staining can be used as a surrogate for the loss of function of ATRX gene. That means the silence mutations of ATRX gene. So interpretation should be careful as some of the native cells may not stain. So no staining cannot be equated with tumor, but tumor cells if you pick it up, you can interpret it. So whenever ATRX loss is there, it's a diagnostic of astrocytic phenotype or astrocytic tumor. But however, it is to be remembered that not always all astrocytic tumors show loss of expression. Mean loss is saying that it cannot be oligodendroglioma, more likely to be astro. However, retain cannot say that it cannot be astro. Is it clear this point?
Yes, sir.
So whenever there is an ATRX loss, there is no need to do 1p19q deletion, irrespective of morphology. So here in this case, ATRX loss is there, so there is no need to do 1p19q deletion. So this is a p53 protein, which is strongly intensity positive. So this indicates like p53 mutant phenotype. So p53 protein expression can be seen like in other tumors can express in the form of variant patterns. When there is a predominant population of cells, strong positivity is called p53 mutant phenotype. Few points. Like IC pattern can be used as a surrogate for p53 mutant phenotype. When what is mutant phenotype? When it is either completely negative or more than 60% of cells are staining with strong intensity positive. Wild type pattern is variable when it is less than 50% and it is moderate intensity or weak intensity. However, you need to understand that p53 IC staining is not an absolute correlation for mutant phenotype. So IC for p3 is only done for the expression pattern of normal protein, not for the mutant phenotype. Is it clear? Vivek, Rupal, is it clear?
Yes, sir.
So this is MIP1 or KH67. Labeling index, how do you evaluate the labeling? It's almost like 1% or 1 to 2% in this case. Okay, very low MIP level. But what is few points to important is MIP1 is also a nuclear strain. It labels all the cells in the cell cycle phase except G0 and T1. Okay, and it is proportional to the mitotic count, but it is not equivalent to mitosis. So always should be interpreted at the highest labeling area. And intensity of staining has no role for the MIP1. You can see few pictures like left side picture is the high labeling and the right side picture is the low labeling. Few points for the MIP labeling. So grading should not be based on the MIP labeling. However, it can be used as a guide for your biological behavior. MIP. Okay, grading in histological features. What are the features is used for the grading?
Mitotic activity.
Mitotic activity, very good. Mitotic activity, microvascular proliferation, and necrosis, and other molecular markers. So coming to this case, current case, what is your impression? You have got IDH mutant phenotype, you have got ATRX loss. What is your phenotype?
Diffuse astrocytoma.
Very good. Anything further you want to add? So it is diffuse astrocytoma, IDH mutant. Histologically, you can grade 2 or 3. In this case, I agree with you. Whatever picture you have shown, it is grade 2. You got some. Okay, then I was trying to show you a picture there, whereas that picture is got a mitosis there. It's a grade 3 tumor. When you see a mitosis in a moderate cellular tumor, histologically grade 3. You can we use CNS-WHO grading? What is the CNS-WHO grading? Any diffusely infiltrating tumor, IDH mutant, your grading starts from 2, 3, 4. It cannot be graded as 1. Any infiltrating tumor in adult diffuse glioma, IDH mutant, whatever it is, either it starts with grade 2. It is not a step-ladder pattern like 1, 2, 3, 4. It starts with a 2 and 3 and 4 depending on the molecular features. Here, WHO, CNS-WHO grading are 2, 3, 4. Can we use CNS-WHO grading in this case? We can't use it because what is the current definition of IDH mutant astrocytoma grade 4? You have any tumor which exhibits histological features of microvascular proliferation or necrosis or molecular feature of CDKN2A 2B homozygous deletion. If you have any of the three features, it will qualify as grade 4. Here, have you evaluated for CDKN2A 2B homozygous deletion? We have not evaluated. So we cannot use CNS-WHO grading. We have to use histological grading. Is it clear?
Yes,
when you have necrosis and microvascular proliferation, whether you can use directly histological grade 4. However, for any histological grade 2 and 3 tumors, if you don't evaluate for CDKN2A homozygous deletion, you cannot apply CNS-WHO grading. You have to apply histological grading. Is there any immunohistochemical surrogate for CDKN2A 2B homozygous deletion? Vivek? Or anybody? So there are markers like P16 and MTAP. You can see P16 is not considered to be very robust. P16 expression comes in normal cells as well as this. So lack of P15 or MTAP expression is considered to be a surrogate for CDKN2A homozygous deletion. Here both P16 and this is P16 and MTAP. Both are positive. So what is your final impression now? Your final impression is diffuse astrocytoma, IDH mutant, histological grade 3, and you can put a note: the immunohistochemical findings are not suggestive of CDKN2A deletion phenotype because both P16 and MTAP positive cells are seen. Is that clear? Vivek and
Yes,
clear? So what's the message you got from this case? Any adult diffuse glioma, irrespective of cellularity, we need to evaluate first for the IDH mutation. Then you need to evaluate for ATRX protein expression to segregate further the astrocytic or oligo. And when it is of lower grade tumor, you need to evaluate for CDKN2A deletion. Okay? And the IHC surrogate for CDKN2A deletion are P16 and MTAP. Okay?
Yes, sir.
So next case we'll go. Second person. Read out the history. Who's going to take up this case?
So Dr. Aviral, I think he has not joined yet.
So anybody can volunteer? Vivek?
I can, sir.
Yeah,
Yes,
you
I
can
can.
go ahead.
This is a 60-year-old male presenting with general tonic-clonic seizures since 10 months, and there are occasional tremors also. MRI brain shows a T2 intermediate signal intensity involving the right high
So
frontal lobe.
let me summarize. This is a 60-year-old male. The MRI findings suggest a high-grade frontal tumor. Okay? The debulking surgery was done. Now see the tumor. Can you describe?
Yes, sir.
This is the lowest power view of a tissue section. Can you describe?
It shows hypercellularity.
So
Cellular.
it shows in areas of hypercellularity, which is like ill-defined nodule-like. You can see that.
Yes, sir. Yes,
In the normal parenchyma. Okay. When you go to the higher power, what is it? How are the cells? Unlike the previous one, what is the degree of the cellularity here?
So monomorphic type of cells, sir.
And more cellular than the previous tumor, right?
Yes, sir. Yes, sir.
And what is the typical feature of these cells? Can I go to the higher power, next high power?
Yes, sir.
How is it showing?
So
You
they're
can
showing
see monomorphic oval shaped cells, and they are round, and some cells are showing perinuclear halo. Okay.
oligodendroglioma, sir.
Like morphology, oligodendroglial morphology. What is it marked here?
This one is
It's a mitosis. It's trying to show that it's a cellular tumor. The classic description of a cellular tumor, monomorphic round cell with perinuclear halo. Some people describe as fried egg appearance. Okay, and this fried egg is due to nuclear clearing. That's an artifact in the paraffin processing. In a frozen tissue, we'll never see an clearing. Okay, the clearing is because of the frail cytoplasm. It retracts. So the most important feature for picking up oligodendroglial is monomorphic morphology. Okay, so here you feel it is a cellular tumor. You can see the infiltrative growth pattern, mitotically active. So what is your histological impression?
so oligodendroglioma, sir.
Yes.
And since mitosis is present, sir, it is. Yes, sir.
So oligodendroglial tumor. Better you to say that because you don't know what the definition of WHO classification for oligo, it has to be IDH mutant and 1p19 co-deleted. When you're picking up in morphology, you should say infiltrating glial tumor of oligodendroglial phenotype or morphology with high-grade features. So what is the IHC you want to do it? So there are a lot of mimickers.
IDH
For
one
oligo.
and two.
Yeah,
IDH
there's a lot of mimickers for oligodendroglial. Olic 2 can be done. Olic 2 is a marker of glial differentiation. Olic 2 is a nuclear stain, it is positive. Okay, you can see the nuclear stain is all positive over this. This is IDH. How do you interpret IDH?
So strong positivity, sir.
It's positive. Almost all cells are positive. You can see the endothelial cells are negative. That means it's a 2 stain. What does it mean? It's a norm. What does it mean? It's an IDH mutant. Okay, now you want to do anything further, Vivek?
Yes, further is that we'll check for that correlation of 1p19q, sir.
Before a correlation, you want to do anything else?
ATRX.
ATRX.
Yeah, so if it is ATRX loss, you don't have to. So ATRX. What is ATRX showing here?
Retention.
Yes, it is retained. There is no loss of expression. So oligodendroglial morphology, IDH mutant, ATRX retained. Anything further? If you want to do further, you can do that. This is P53. You can see few cells which are positive. This is not a P3 mutant. So most of the time, P3 mutation means it's unlikely to be oligo. So again, this pattern of IHC for P3 is not like mutant phenotype. It's a normal pattern of P3. So MIP1, this is MIP1. You can put it as in high labeling. Okay. So with this, what is your impression? You will call either way. Diffuse glioma, IDH mutant of oligodendroglial phenotype, histologically grade 3, or probably oligodendroglioma NOS, CNS-WHO grade 3. Why NOS? Because you're not done 1p19 deletion. Whenever any molecular test you're not doing, you need to suffice as an NOS as per the WHO. Either way, you can go it. So as you already told, anything further, you need to do 1p19 co-deletion. Here in this case, it is 1p19 co-deleted. The final impression is oligodendroglioma, IDH mutant, 1p19 co-deleted, histologically grade 3 or CNS-WHO grade 3. Okay. So any further? Because like an astrocytic tumor, for oligodendroglioma also, grading protocol can be used for CDK2 deletion. You can do for that also, and this is a marker of ScreenRecording ME3. In an IDH mutant tumor, you have done ScreenRecording 27Me3. You see the endothelial cells and normal cells are coming positive, and there are a lot of cells which are negative. There's an underexpression. What is the significance? It is a surrogate for 1p19 co-deletion. When you have IDH mutant ATR is retained oligodendroglial morphology tumor, STK27ME3 loss is considered to be a surrogate for 1p19 co-deletion, but it is not equivalent. When you say that almost all 100% cases when there is under expression of ME3 are 1p19 co-deleted. Anything further? Like P16. P16 you saw the previous case. What is it here?
This positive.
Positive and MTAP. Positive. What is P16 and MTAP positive telling? It is not showing a
Poly-
CDK2 deletion. It is not showing. Only loss of P16 and MTAP is equal to the CDK deletion. Okay. So your impression is in whichever way you want to do it, you can add a note to that. Immunohistochemical findings are not of CDK2 deletion phenotype, and you need to advise for 1p19 co-deletion. Okay. That's a molecular fish method. Ideal way you can do that. Then only you can give an integrated diagnosis. Without doing 1p19, you cannot give an integrated diagnosis. Is it clear?
Yes, sir.
So third case, because you wanted to take Vivek,
Silent.
a 21-year-old male who had one episode of seizure and there is a left frontal as well with necrotic areas, with that mean like it's a high-grade morphology. Histology showed like this. Can you describe?
So there are large cystic areas, sir.
So first thing what we described is cellularity. Is it looking normal or more than normal cellular? And that is power.
It's hypercellular, sir.
It's definitely more cellular and no architecture, and interspersed is microcystic spaces. When you go down higher,
Yes, sir.
what is it showing? Can I go to the next part? Maybe this is better. Yeah.
So it's showing, sir, many microcystic.
That you can pick it with the low power. When you're going to the higher power type, what are the type of cells?
So various type of cells.
Again, it is having a mixture. There are many cells which are oligo-like morphology, clearing,
Yes, sir.
mitosis, microcystic spaces. But this is a little bit different from the case what you saw in the second case, and variation is a bit more than the second and less than the first case. Is it true?
Yes, sir. Yes,
And
sir.
higher grade, mitotically active. You're not seeing any necrosis and microvascular proliferation. So
No, sir.
what is your histological impression or IC panel you want to do it? Yeah,
So,
high grade,
IDH.
IDH, very good. So this is first thing you need to do OLIC2 when you say that whether it's a glial or not. Okay,
Yes,
it's
sir.
OLIC2 positive. OLIC2 positive tells it's glial, but negative cannot be saying that it cannot be glial. Okay. Now this is IDH. How do you interpret IDH here?
It's negative, sir.
It's negative, so it is not cytoplasmic positivity because IDH is a all or none phenomenon. So it cannot be focal, it is negative. So what does it mean?
IDH
IDH is not IDH1R132H mutant. It tells you that only this mutant is not there. Next, what marker you do?
ATR.
Yes, interpret ATRs here. How are you interpreting ATRs here?
So I think it's negative.
Loss of expression, very good. Because you can see the endothelial cells are all positive, the normal cells are positive, but the tumor cells are all negative. So you need to say the loss of expression. So what does it mean? ATRs loss of expression mean?
So it is.
It is not oligodendroglial.
Not oligodendroglial.
It is likely to be astrocytic phenotype, right? ATR. So P53, what do you interpret P53 here?
Negative.
Completely negative. No single, not even one cell. It is a typical pattern of null type pattern. So can be 50 mutant also this one pattern. It's completely negative. Can't be put as normal. Completely negative. This is MIP1. MIP1 is all case. One is higher. So where do you put an impression here?
So grade 3 or 4, sir.
But what are you going to call?
It is of.
So you have to call diffuse glioma infiltrated astrocytic phenotype because ATR is lost. And histologically at least grade 3 because you're seeing mitosis, necrosis and MVP not there. Though the radiologically is higher grade, but we can call at least grade 3 histologically. Anything else you want to do it now? Can we call IDH? This is glioblastoma, IDH mutant, IDH wild type.
So we call it mutant type, I think, sir.
Why? IDH is negative, no?
Yes, sir, it is negative.
So we know the WHO grading as 3 groups. Astrocytoma IDH mutant, oligodendroglioma IDH mutant, and glioblastoma IDH wild type. So can we say this is glioblastoma because IDH is negative? No. IDH1R132H is only picks up one common type of mutation. There are many mutations of IDH1 and IDH2 which cannot be picked up by IHC. Okay? Any younger patient, like this case, suggestion is you need to suggest for tag sequencing and it is shown a typical variant other type of mutation, IDH1 mutation. Okay? So few things now because of the mutant, you have to call diffuse astrocytoma IDH mutant, at least histological grade 3. So where do you do the sequencing? So evaluate any further suggestion because you need to evaluate for CDK2 deletion. If it is deleted, you have to call it is grade 4, IDH mutant grade 4. If it is not deleted, you have to leave it as grade 3 histological grade 3. So where all few points to remember on adult diffuse glioma, you need to say that 85% of all mutation adult diffuse gliomas of IDH mutations are IDH1R132H mutation, which can be tested by routine immunohistochemistry. Okay, but there are 15% of cases where you may not get IDH1R132H mutation, which requires sequencing. Which are those cases which you subject? Any cases which are ATRX loss, any cases which are oligodendroglial morphology, any cases which are histological grade 2 or 3 morphology has to be subjected for sequencing. If ATRX loss, it cannot be OTG, oligodendroglial tumor, it has to be so there is no need to do 1p19 deletion in cases where ATRX loss. Okay, but what you need to understand is not retained. ATRX retained is not equal to oligodendroglial. There you need to subject for other molecular investigation to call something as oligodendroglioma. One soft point is diffuse and strong positivity P53 is unlikely to be oligodendroglioma. These are the few points which you need to remember on immunohistochemistry. When somebody asked in the chat box, like when to do GFAP, when to do OLIC2. So GFAP has no role in the diffuse gliomas, GFAP matrix positivity. All IDH mutant tumors are OLIC2 positive. So when you get an IDH mutant, you don't have to subject for OLIC2. So OLIC2 can be used especially when cases when you're in doubt in diagnosis, like whether it's a glial or not. So barring few exceptions, most of the time OLIC2 positive tells you it's glial. The subset of glial tumors where OLIC2 is negative is appendiomas. So when you want to distinguish between infiltrating or diffuse glioma and appendiomas, you can use OLIC2. Appendiomas are OLIC2 negative. So these are the situations which you can use it for OLIC2. It is not equivalent as GFAP. Understood? There are many gliomas which you see today in cases where OLIC2 can be negative that can be also used as a morphological marker for certain subset. So anything. So what is the WHO classification for adult diffuse glioma? There are 3 subtypes: IDH, astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19 co-deleted, and glioblastoma which is IDH wild type. What you need to understand is all diffuse glioma, adult diffuse gliomas are graded 2, 3, and 4. And glioblastoma is only the term reserved for only adult diffuse gliomas where IDH is wild type. Okay? Is it clear? There are no adult IDH wild type astrocytoma which are grade 2 or 3 tumors. It cannot be. Okay? So this is the current grading criteria. When you have an IDH mutant, you need to evaluate for histological features. When you have MVP or necrosis, it is grade 4. When you don't have MVP or necrosis, you need to evaluate for CDK2 or deletion. This can be qualified as grade 4. Similarly, for glioblastoma, whether it's IDH wild type, they need diffuse astrocytoma with no IDH mutation, either with histological features of high grade or with molecular features of easier for amplification, third chromatin mutation, or combined chromosomal 7 gains and loss of chromosome 10. These are glioblastomas. Any questions regarding adult diffuse glioma?
Yes, sir, there's one question in the chat box about cutoff for ATRX, when to call it loss or retained.
So ATRS cannot be used as a cutoff for that. You need to take a call. So if it is P3 mutant phenotype, you can use it. IDH mutant, if the cells are IDH mutant positive cells, you can see that as a surrogate. But you cannot use as a quantification cutoffs as this. They are subjectively evaluate. If you can't evaluate, probably you can use as a mosaic pattern staining, or you have to see that as an evaluation for it. But you cannot use as a cutoffs. So P3 strong intensity positive cells are tumor cells. IDH positive cells are tumor cells. You need to evaluate those cells. What are the expression of ATRX on that? So when there are a lot of admixture of normal cells, I agree ATRX interpretation will be difficult. There you can leave it as equivocal, or you can leave it as mosaic pattern. So this is all for the residents, like for the revised schema of classification, how you do it for the identity diffuse gliomas. When you have an identity diffuse glioma, first evaluate for IDH mutation. If it is mutant, either it can be oligo or it can be astro. And if it is histological high grade, no need to do for CDK2 deletion. If it is lower grade, you evaluate for CDK2 deletion. If it is deletion, it is grade 4. If no deletion, you can grade it as per the histological grading, 2 or 3, that based on the merits of mitosis. If it is IDH mutant, ATRX retained and oligomorphology, this is for oligodendroglioma, and you need to evaluate for 1.94 deletion. If it is deleted, it becomes oligodendroglioma. If it is IDH wild type, you need to see for the histology. If it is higher grade tumor, it calls glioblastoma. IDH wild type, it is lower grade, you evaluate for the other molecular markers. Okay. So any other questions you have other than ATRX interpretation?
No, sir.
No, sir.
So is it clear? Take home message for identity diffuse glioma, because we'll move on to the second group of cases. Is it clear?
Yes, sir.
So at least acquaint yourself identity diffuse gliomas, IDH, ATRX, and some of the surrogates like P16 MTAP for CDK2A, and oligodendroglioma S3KB3 can be used as a surrogate for 1.94 deletion. The next group of cases.
Dr. Vibha and Dr. Ruby, please introduce yourself.
Yes, good evening, everyone. My name is Dr. Vibha, and I'm a second year postgraduate from Kasturba Medical College, Mangalore.
So Vibha, you will take up this case?
Yes, sir.
Okay, for your this thing, I will read up the history. See, the 22-year-old, and he showed a right frontal mass with infiltrative pattern. Infiltrative means diffuse, and there are enhancement areas, means restriction. Enhancement and restriction tells you that radiology is high grade. So what? Now you can take this. Can you describe this?
Yes, sir. So the tissue that we're seeing looks highly cellular, and I see some areas of congestion.
Do you see any giant cells also at this part?
Yes, I see giant cells.
So there are predominant population of cells are one type, and few scattered cells of bizarre pleomorphic cells are also there, right?
Yes, sir.
Can you go down higher? You want to describe here?
Yes, sir. These cells look pleomorphic.
And predominant cells are literally undifferentiated. You are not seeing any matrix, right?
Yes, I see mitosis, and
Yeah.
they have a highly pleomorphic
Yeah, we
nuclei.
have other images also. You can see this image. You can see the large cells. So the predominant
Yes, sir.
populations are round and differentiated, but there are large bizarre pleomorphic cells, right?
Perfect cells.
So what
Yes,
is
sir.
your line of thought process? Like, where do you put this? When you get such a highly cellular tumor, predominant areas of undifferentiated, radiologically histologic infiltrative, what should be your IC panel?
So IDH1 R132H.
No, but are you clear that it's a glial?
No.
So then, do you want to do anything for the glial?
So for glial,
So the first thought process I'll tell you, because you have saw the histology is quite undifferentiated area. Whenever you see this, you will have a doubt in your mind: is it a glial or an undifferentiated embryonal cell tumor, right?
yes, sir.
But what are the soft points here is an undifferentiated or embryonal tumor really ever show this bizarre pleomorphic cells. Okay, like these. So these are the hints. Probably you're looking at a high grade tumor which is mimicking like an embryonal tumor. Okay.
Yes, sir.
So the first line which you want to do it is to verify whether you're thinking of glial is right or wrong. Okay. You do an OLIC2. Sorry, IDH has been done. IDH, how do you interpret?
So it's negative.
So negative. So what does it tell? Are you clear anything? We are not clear. Any other marker now?
So it tells us that it is wild type and not a
No,
mutant.
it's not wild type. I told you now only, right? It's only negative for this mutation.
You should,
Unless
yes.
we don't. At least we are not saying it's IDH mutant. We don't know wild type or not. To know it's
Okay.
wild type or not, you need to do the sequencing, right?
Yes.
It's
Yes,
only
sir.
negative for this mutation.
Okay.
So you are thought about glial tumor, which is mimicking like an embryonal tumor. IDH is negative. So until now, you don't have any kind of help for you, whether are you looking at glial or an embryonal tumor, right? The next marker
Yes.
which you do is an ATRX. How do you interpret the ATRX?
So ATRS expression is lost.
The loss. So did you see any case previously where ATRX expression lost but IDH is negative? So you saw the third case of the first case group 1 where IDH is negative but ATRX lost.
Lost.
Keep sequencing proper. We got it. So at least ATRX loss means it's telling you an astrocytic phenotype. Okay. No
Yes,
embryonal tumor will have an ATRX loss. So now that you know that ATRX loss, you need to know whether you want to do IDH mutational sequencing or not. So any further for your IC you want to do it? This is P53. How will you evaluate P53?
so it's strongly positive.
So when you have an ATRX loss and strongly positive for P3, this is a P3 mutant phenotype, which tells you that you're looking at a glial. But we have
Yeah.
not seen any GFAP or anything. Ideally, if you have to see, we need to evaluate for IDH mutation, right? To see whether IDH, because you got a phenotype of ATRX loss. Any
Yes,
further
sir.
you want to do it before you subject for the sequencing for IDH? In previous cases of IDH mutant cases, we saw OLIC2 positive in all cases, right?
Yes, sir.
So now you do the OLIC2. OLIC2, how will you interpret this?
So this is negative.
So can this be an IDH mutant? All IDH mutant tumors are OLIC2 positive.
Positive.
Yes. So now you are having a unique situation. It has got a very highly cellular tumor with predominant areas of undifferentiated, but overall morphology looks like glial. It has got an ATRX loss, astrocytic phenotype. IDH is negative. P3 mutant phenotype. OLIC2 is negative. Do you think of any tumor subset? You did for synaptophysin weakly positive.
Yes,
But
sir.
don't interpret synaptophysin in a brain tumor like that. All glial, any neuronal tumor can show positive. It does not mean anything. Just because synaptophysin positive, you don't run away from the glial because you need strongly you have an ATRX loss. Okay. So what should we do? You do evaluate for H3.3 G34 mutation. So there is an entity called diffuse hemispheric glioma H3.3 G34 mutant tumor which will have ATRX loss and OLIC2 negative, which is seen in younger adults. This can be done by IHC. Is again nuclear. It's a mutant specific antibody. You can see this positive for R.
Yes,
Just
sir.
like IDH1 R132H, but that is an cytoplasmic. That's a mutant specific antibody. This is H3.3 G34R. This is a mutant specific antibody. It's a nuclear antibody. It is positive, but whenever you evaluate for G34 mutation, you need to do for R, V, and W. Here we have done V and W are negative, and R is positive. Okay, is it clear?
Yes, sir.
So what is your impression?
Yeah.
It should be diffuse hemispheric glioma, H3G34 mutant, R mutant. You can CNS grade 4.
Grade 4.
You can see you can pick this entity even by immunohistochemistry by subjecting mutant specific antibodies. Whenever you suspect G34 mutant, when the tumor have ATRX loss and OLIC2 negative, IDH is negative. Is it clear?
Yes, sir.
Huh?
Yes, sir.
Okay. So this diffuse hemispheric glioma are grade 4 tumors. Histologically can show variable degree, can show all features of high grade. Typical phenotype is OLIC2 negative, ATRX loss, T3 immune phenotype. Definite diagnosis is detection by G34 mutation, either by HC or by sequencing. Is it clear?
Yes, sir.
This is some of the pictures you can see. There's a high grade can show a typical picture of a high grade glioma, and they can show ATRX loss and OLIC2 negative, P3 mutant. And if you do for ME3 will be retained. Now the second case in this group, who is going to take up?
Dr.
Ruby. So Ruby, this case is a 16-year-old girl who had presented with headache with short history. Radiologically thought to be a large intraventricular mass, but when carefully evaluating, it is seen infiltrating the thalami and also corpus callosum. Biopsy could be done. Can you describe this?
This is very highly cellular neoplasm.
So this is a tumor which is highly cellular. Okay, monomorphic cells. Any further? Let me go to the higher magnification. You want to describe any further?
Few microscopic.
So it has got a little bit of clearing as well, but irregular oval, but cellularity, right? Pleomorphism is not striking. Variation in size is not striking. More or less monomorphic and branching thin wall vasculature. Will you entertain an oligodendroglioma?
Does not have a typical side of the
Never ever entertain oligodendroglioma in intraventricular mass. Okay? Whenever you have any intraventricular mass, oligo-like morphology mean it can be a glial, any diffuse glioma, or it can be a neurocytic tumor. But this is a high grade, so it is not like to be neurocytic. So your differential has come to you as an intraventricular mass, mitotically active, which has got a monomorphic cells, which has some resemblance to oligo-like morphology. What do you want to do? So first you need to rule out whether any neurocytic neoplasm or not. So the marker for neuronal marker, synaptophysin done, D1 is done. Both are negative. So what does it tell? Anything else you want to do? Yeah, OLIC2. How do you interpret OLIC2? So when OLIC2 positive with this morphology, what is your line of thought process?
Glioma.
Yes, glial tumor when cellularity mitotically active, high grade glial tumor. Anything else you want to do it?
IDH.
So you want to do the IDH? IDH, how do you interpret this?
Negative.
So IDH is negative. Anything further? Anything else you want to do it?
ATRX.
ATRX. How do you interpret ATRX?
43.
So where do you stand now? Anything else you want to do it?
P53.
Yes, P53, P53. What do you want to do? Call P53 here?
Positive.
So diffuse pattern, P3 mutant phenotype, right? Can you think of, will you like to do anything molecular? So IDH is negative, ATRX is written, P3 immunophenotype. Which line of thought process you do? OLIC2 is positive, glial tumor, P3 mutant phenotype. Location, any hint for the location? Midline location. Young girl, 16-year-old.
Diffuse midline glioma.
Yeah, one always should keep an differential of diffuse midline glioma. What do you do for diffuse midline glioma?
ScreenRecording 27.
So ScreenRecording 27, ME3 you should see. What you'll get? What can you interpret here? ScreenRecording 27, ME3?
Negative.
It's a loss. So
Loss,
any
okay.
high grade tumor, midline location, ME3 loss. What does it tell you? It's diffuse midline glioma. Okay. So anything else you want to do it? If you want to characterize further, you can do the 27M mutant specific IHC. You can see again nuclear positivity. All the endothelial cells are negative. So the tumor cells are positive. So is it positive? So normal cells will not be positive. Whenever you get positive for M means it's a mutant. So what do you want to call now?
Diffuse.
Very good.
W2 grade.
Grade, WHO grade what?
4.
Yes. So this is one entity where you have hemispheric glioma and H3G34 altered and H3K27 altered tumors. Even though you don't see classic histological features of grade 4, they will be classified as grade 4. Okay. We only saw mitosis. We not saw necrosis and MVP are not seen, but it's still called grade 4. So you understood what the two different tumors were histone mutant. Both the histone mutant has got a mutant specific IHC panel. IHC can be used to pick up these entities. Is it clear? So what is diffuse midline glioma? One thing it should be diffuse infiltrative growth pattern. Okay, and it should be midline location. At least what do you mean by midline location? If involving thalamus, cerebellum, or cerebellar parenchymal brainstem, spinal cord, pons. Anyway, there are three subtypes. It can be mutant subtype, it can be EGFR altered, it can be either 4 expression. But one thing common for all three is loss of ME3 protein expression and IHC, which you saw here. All are grade 4, but you need to understand not all high grade tumors in midline are diffuse midline, but all diffuse midline glial tumors in the location are grade 4 tumors. Molecular evaluation is not absolutely mandatory if you get an ME3 loss and diffuse infiltrative pattern, but in clinical trial setting you may require for this thing. Okay, the third case in this group, anybody? Maybe Ruby, you will need to take. Third case, 15-year-old boy, left frontal SOL. This is the picture. What do you want to call? Yeah, you can see large areas of necrosis and this viable tumor is scant. This is the viable tumor. Can you describe this?
Highly cellular neoplasm, showing pleomorphic cells and giant cells with microtic activity.
So it's a highly cellular tumor, giant cells, mitosis are also seen. You got necrosis also. Where do you club this tumor now? You can see this. And what are these picture? What are you seeing here?
Giant
Microvascular proliferation. Yeah. So you got all features: cellular tumor, nuclear pleomorphism, mitosis, microvascular proliferation, and large areas of necrosis. What grade is this?
grade 4.
It's a glial morphology. Matrix is papillary grade 4 tumor. So what do you want to do? Anything you want to do it? So this is OLIC2. What is it? OLIC2? Positive. So it is not like hemispheric glioma because younger patient because diffuse hemispheric glioma is G34 mutant will be OLIC2 negative. So this is OLIC2 positive. Okay. Next panel you want to do IDH. IDH how do you evaluate?
Negative.
Very negative. So now what is the next marker you will do?
ATR.
ATRX. What do you will interpret here?
ATR is 53.
Then next marker you want to do?
P53.
P53. How will you interpret?
P53 positive.
Yeah, it's positive. Not like typical pattern of mutant phenotype, moderate staining, but it is positive.
Yes.
And this is MIP1. As you know, it is high grade. It's very high labeling.
Hypoxic.
Yeah. So what else you want to do it now? You have got high grade glial tumor. IDH is negative. ATRX retained. Probably P3 mutant phenotype. So OLIC2 is positive. ATRX is retained. What else you want to do it?
P27.
So ME3, A27 ME3. Yeah. What is it saying?
And so it is 3 things.
So will it be a diffuse midline glioma?
No, sir.
It cannot be diffuse midline glioma. So ME3 you did it. So where do you stand now?
The pure hybrid glioma.
So you will like to rule out other mutations, some rate types. Other IC has been done for G34R, B, and W negative, and BRAF also was done. All are negative. Okay, IDH1 no mutation, probably 132 is negative, and other histone S3K27 and G34 S3.3 mutations are negative. Where do you want to classify? So this is high-grade glioma tumor of astrocytic morphology. Because young patient, we don't know whether pediatric or an adult type. IC finding is IDH wild type phenotype because astrocytic morphology, but no ATRX loss. Okay, S3K27 again retained expression, so wild type phenotype. S3.3 is again wild type. So whenever you have an younger adult high-grade glioma tumor, giant cells, which you don't see any IDH or histone mutation, probably you look for any other syndromic association. Okay, like here we've done for MMR proteins. MMR proteins is what? MSH2, MSH6, MLH1, and MPMS2. So you can see here MSH6 protein is lost in the tumor cells, retained in the endothelial native cells. So this is a MMR altered phenotype. So you need to understand that whenever you have an IDH wild type and histone wild type, there can be a subset of syndromic associated tumors like MMR altered. You can do by IHC, doing by MMR protein. Simple thing by showing you the retained expression or loss of expression. So when you get loss, how will you say that this is impression, glioblastoma, NOS, because we have not done molecular testing, but more likely IDH wild type, histone wild type, S3 wild type, MMR deficient, and CNS grade 4. Is it clear? Okay.
Yes, sir.
So the fourth case of this group is anybody else want to do it? 3-year-old girl, right frontal as well. 3-year-old boy, right frontal as well. I will only take up for this case. So 3-year-old right frontal as well. You can see a cellular tumor, bizarre morphology and mitotically very active. Okay. Whenever you see an infantile tumor, high-grade glioma tumor, you evaluate ALK, IHC, whatever it is showing diffuse positivity. This entity is called an infant type hemispheric glioma, ALK rearranged. So this is again WHO grade 4, or we cannot, as currently WHO classification has not graded these tumors, and you need to leave it as infant type hemispheric glioma, ALK rearranged. Sorry, we did it for grade 4 because histology like that, you don't have to mention grade 4. So what are these tumors? Like infant hemispheric glioma tumors are those tumors which are characterized by ALK, ROS, NTRK, and MET alteration. Whenever you get these alteration in pediatric population, especially in the age group of 1 to 3 years, you label it as infant type hemispheric glioma. So the importance of evaluating is there's a distinct role of targeted therapy. This is another subset of pediatric type of glial tumors. Currently, WHO does not grade these infant type of hemispheric gliomas. Okay, is that clear? So in this group of tumors, we have seen the pediatric type of high-grade tumors where you saw diffuse hemispheric glioma, S3.3 G34 mutant group, diffuse midline glioma. Okay, it's IDH and S3 wild type glioma where MMR altered you saw, and one case review about infant type of hemispheric glioma. Is it clear? These are the subset of tumors for pediatric high-grade tumors. Any questions regarding this?
Nothing in the chat box.
Nothing. So can we move to the next group of tumors?
Yes, sir.
Yeah, this is a group 3, more or less similar kind of cases, but a little bit different subset of tumors. So 27-year-old male presented recent history. However, radiologically showed a solid cystic lesion in the temporal lobe. It tells you it is not showing any infiltrative pattern. It's a solid cystic lesion. Okay. So what is the histology? Who is presenting?
Sir, Dr. Shruti, sir. Good evening, sir. I'm Dr.
Shruti, can you describe this?
Sir, this is hypercellular smear.
Very good. Hypercellular like it. So is it tumor or non-tumor?
Sir, it is tumor.
Definitely no resemblance to the native parenchyma. Very cellular. What is it composed of?
Pleomorphic cells and spindle-like cells, and there is
Yeah,
some
you can say spindle-like cells, in short bicycle-like or elongated cells, it mixed with large bizarre pleomorphic cells, right? And some inflammatory cells are also, you can see dot-like cells, right?
Yes, sir.
You can see the inflammatory cells in this, and few bizarre pleomorphic cells. You can see that. What are these? Any additional finding in this picture?
Sir, there is giant cells also.
Yes. And what you can see, a large foam cell you can see here, a granular pale cytoplasm.
Okay, sir, let's-
There are foam cells and there are pigmented cells also, right?
Yes,
So
sir.
radiologically young male, temporal as well, solid cystic mass, a tumor which is going spindeloid-like cells, vesicle, interspace with large bizarre cells, some foam cells, some inflammatory cells. What is your thought process, line of thought process? Is it a tumor or not? Shruti, is it a tumor or not?
Sir, it is tumor.
Definitely tumor. So
Yes, sir.
is it glial or not glial?
Sir, it is glial.
So how do you evaluate to know whether glial or not?
Sir, ISC by ISC.
What IC you want to do it?
Sir, okay. IDH.
So before that, you want to do anything to prove whether glial or not?
Sir, only 2.
Yeah, okay, you wanted IDH. IDH is here. How do you interpret IDH?
Sir, IDH negative.
Very good. Sometimes you can get this faint brown light, but it is not positive. It is negative. Okay.
Yes.
So this is next ATRX. What do you interpret ATRX?